Hi, my name is Abdul Kouanda. I'm a third year GI fellow at UCSF. We thank GIE for the opportunity to present our work here today.
My name is Patrick Avila. I'm an advanced endoscopy fellow at UCSF.
And I'm Ian Holmes, GI Fellow at UCSF.
Together, we will be summarizing our group's upcoming paper in GIE titled Practice Patterns of Post-ERCP Pancreatitis Prophylaxis Techniques in the United States, a Survey of Advanced Endoscopists. Patrick, tell me about how this project came about.
Post-ERCP pancreatitis is a feared adverse event for all of us that perform ERCP. We sought to describe the current practice patterns in the prevention of post-ERCP pancreatitis among advanced endoscopists involved in advanced endoscopy fellowship programs in the United States. There are conflicting guidelines and approaches to the optimal strategy for the prevention of post-ERCP pancreatitis. For instance, ASGE recommends prophylactic pancreatic duct stenting and rectal endomethacin to reduce the incidence and severity of post-ERCP pancreatitis in high-risk individuals only. The ASGE guidelines do suggest that rectal endomethacin may be helpful in average-risk patients as well. However, they do not go so far as to endorse the use in all patients. Meanwhile, the European Society for Gastrointestinal Endoscopy recommends rectal endomethacin for all patients undergoing ERCP.
Why would we do prophylaxis for all patients instead of just high-risk patients?
Well, the current evidence to suggest that the routine use of rectal endomethacin in average-risk patients to prevent post-ERCP pancreatitis comes from a number of sources. There's a 2016 randomized controlled trial from China that showed significantly reduced rates of post-ERCP pancreatitis in average-risk patients, as well as a large 2016 retrospective cohort study that showed a similar reduction in post-ERCP pancreatitis. Additionally, there's a 2017 meta-analysis of all rectal NSAID randomized control trials that showed reduced post-ERCP pancreatitis rates in average-risk patients. However, previous studies of European endoscopists revealed low adoption of pancreatic duct stenting or rectal endomethacin to prevent post-ERCP pancreatitis.
What was the methodology used to address this question?
We developed an anonymous 16-item online survey. We asked respondents if they use rectal endomethacin or pancreatic duct stents for post-ERCP pancreatitis prophylaxis, and whether they did so for all patients or for high-risk patients only. We defined high-risk patients as those requiring pancreatic or precut sphincterotomy, traumatic biliary sphincterotomy, balloon dilation of the biliary sphincter, injection of the pancreatic duct, extensive pancreatic duct instrumentation, difficult cannulation, suspected SOD, a history of previous post-ERCP pancreatitis, female gender, or advanced age. Respondents were also asked about the clinical setting of their practice, whether they worked with fellows, and whether they used other techniques for post-ERCP pancreatitis prophylaxis, such as octreotide, antibiotics, or the use of rapid IV fluids. The survey was distributed to 233 advanced endoscopists involved in advanced endoscopy fellowship training programs as listed on the American College of Gastroenterology's fellowship portal.
Let's discuss the results. What did you find?
Well, our response rate was 26.7%. Around 3/4 of respondents reported using pancreatic duct stents in high-risk patients only. Only 6.8% of respondents used pancreatic duct stents in over 3/4 of the ERCPs that they performed. Over half of the respondents who infrequently used pancreatic duct stents cited concerns about increased risk for post-ERCP pancreatitis if they were unsuccessful in placing a pancreatic duct stent. Around a third believed that stents did not provide any additional benefit on top of a pharmacologic prophylaxis.
How about for rectal endomethacin?
Well, 98.4% of our respondents used rectal endomethacin, with around 40% of respondents using it in all patients and 60% using rectal endomethacin in high-risk patients only. Nearly 70% reported using rectal endomethacin in more than half of the ERCPs they performed. 83% of respondents also used rapid IV fluids to prevent post-ERCP pancreatitis.
What are the main takeaway points that you want readers to understand from your article?
Well, overall, we found that American advanced endoscopists are much more likely to use rectal endomethacin than pancreatic duct stents for post-ERCP pancreatitis prophylaxis. Prior studies, mostly European endoscopists, have found that lack of experience is a major barrier to using routine pancreatic duct stent placement. Although no one in our study cited lack of experience as a barrier, they did voice concern about technical aspects of pancreatic duct stenting, mostly about the possibility of post-ERCP pancreatitis if their attempt to place a stent was unsuccessful. It is not surprising then that our respondents reported a higher adoption of rectal endomethacin, a non-procedural prophylaxis technique.
Despite mounting evidence suggesting the efficacy of rectal NSAIDs in the prevention of post-ERCP pancreatitis prophylaxis in average-risk patients, adoption has been slow in the United States. Less than half of the respondents in our survey reported using rectal indomethacin in average-risk patients, which likely reflects that its routine use has not been codified in our national guidelines.
It is important to note that although both pancreatic duct stenting and rectal indomethacin have been established as independently effective techniques for the prevention of post-ERCP pancreatitis, data directly comparing stenting with rectal NSAIDs is still lacking. An ongoing multi-center randomized controlled trial of rectal NSAIDs versus pancreatic duct stenting in patients at high risk of post-ERCP pancreatitis by the Al-Munzer group seeks to fill this gap in the literature. However, our results show that even among experienced advanced endoscopists who practice in tertiary care referral centers and trained advanced endoscopy fellows, application of evidence-based post-ERCP pancreatitis prophylaxis techniques is less than expected.
Thank you, Patrick. Thank you, Ian. And we thank GIE for the opportunity to present our work here today.